Hi, my name is Laura Griffin. I'm chair of the Osteopathic Principles and Practices Department at University of Pikeville, Kentucky College of Osteopathic Medicine, and I'm going to be talking to you today about the osteopathic approach to treatment of patients who present with upper extremity pain. What we will do is just very briefly look at some anatomy that is pertinent to the kind of patients we'll be talking about. We'll look at some physical exam skills that will help us differentiate between radiculopathy, thoracic outlet syndrome, and some of the other sources of upper extremity pain. We will look at the structural exam for these same regions and talk about the ways some of these patients present clinically, and then review some techniques that I have found useful in patients with this kind of a problem. When we're talking about the cervical spine, we want to be cognizant of a couple of things. The most important thing is to understand that the transverse processes are not what we are using to examine the cervical spine. We are actually using the articular pillars right in through this region, right through here. These are actually transverse processes, and they are not, they're bifid and asymmetrical sometimes and not that useful, whereas the facets actually sit right on those articular pillars. So that's the region that we'll be evaluating the cervical spine for motion restrictions. And we want to be aware of where those neural foramina sit in between, kind of just beneath the transverse processes anterior to the facets, so that that is the area that the nerves emerge from and is the area that we need to be cognizant of in terms of certain syndromes that we'll be looking at. The other really important structural component of the cervical vertebrae that's very different from the thoracic and lumbar spine is that we have these uncinate processes here, which then articulate directly with the vertebra above. So they're sort of saddle-shaped vertebral bodies. And this is different. There, in the rest of the spine, there is a articular disc that separates the vertebral bodies from the ones above and below it. So there's no direct connection in a normal healthy spine in the thoracic and lumbar regions. In the cervical region, however, we do have direct contact. There's actual synovial joints there, which means that they're intended to be contacting and they're intended to be moving. But because of that, they get a little bit more direct wear and tear, and you can develop quite a bit of degenerative joint disease in that area, osteophytes, that can grow in towards that intervertebral foramina where that nerve is emerging. So that's one of the things that we'll be looking at as a potential cause for problems. The thoracic vertebra, the upper thoracic vertebrae are important in patients with upper extremity pain for many anatomical reasons that we're going to be getting into, but it's important to recognize the big change in motion characteristics from the cervical spine, where we had somewhat more horizontally oriented articular surfaces compared to more vertically oriented articular surfaces in the thoracic facets. And then the thoracic spine has the relationship with the ribs. So the transverse processes in the thoracic spine articulate with the ribs, as well as where the rib head comes in and attaches to the vertebral body as well. And that relationship is very important when you're thinking about any patient with thoracic somatic dysfunction, because when the rib comes in and articulates, it articulates with the transverse process and then the body of the same numbered vertebra and the vertebra above. So if you have rib dysfunction that you're having a difficult time correcting, then you want to look at both of those vertebral bodies. The first rib, because of patients with, say, thoracic outlet syndrome, is very clinically important because it is different from the rest of the ribs in that it articulates only with T1 down through the ribs 2 through 10. They articulate with 2 vertebrae like we just described. But the first rib articulates only with T1. And when it articulates with the manubrium, it's a very fixed synoarthrodial joint that does not move very much. So when you get this complex of the thoracic inlet, which becomes confusing, because when we talk about thoracic outlet syndrome, we're really talking about the same anatomic region, which is why some people prefer the term superior thoracic aperture. But when you look at this complex, you've got T1, you've got that broad, flat first rib coming in and articulating with both the body and the transverse process, and then coming around and attaching to the manubrium in a very fixed, not very movable joint in that spot. So the thoracic inlet becomes a very stable, not very flexible, bony ring that, when it does experience somatic dysfunction, becomes very clinically significant for the effects that it can have on the rest of the body. And this is just another view that with the clavicle, the sternum has been removed, but the clavicle is still in place. And so you can see that this is a very kind of tight, narrow space between the clavicle and that very broad, horizontally oriented first rib right there. The superior thoracic aperture, as we just said, is one term that some folks like to use, and those are its, the things that make it up. It's very stable, as I said, because of the nature of those articulations that are different from the way the ribs articulate, both anteriorly and posteriorly. And it is a big anchor of support for the upper extremity back to the axial skeleton, because via the clavicle, that is the only place that the upper extremity will attach back to that axial skeleton. So when you have upper extremity dysfunction of any sort, it's going to get, it can be affecting the whole upper thoracic and rib cage because of that relationship, and vice versa. When people have dysfunction in that stable bony ring, it can very easily transmit down into the extremity, or the extremity will have to compensate for that. Just another shot of the sternum from behind, where that first rib comes in up against the sternum, and then the notch for the first rib and clavicles sitting directly next to each other. And here again is that joint of the first rib. It is intended, of the clavicle with the sternum. It is intended to have a lot of motion because of, it's got an articular disc, which is not a common finding in those particular types of joints. And so you know that it is a joint that's supposed to have significant amount of movement. And all the big movements that people do with the upper extremity are going to be transmitted back through the axial skeleton through that joint. The contents of the thoracic inlet are important, vital structures that are traveling to and from the entire body. The viscera, the gastrointestinal viscera coming from the mouth, passing down through to the gastrointestinal system, passes through there. Major vascular structures to and from the neck, and then down into the thorax. A large portion of the nervous system through the sympathetic chain, and some of the parasympathetics coming from the cranium and the phrenic nerve, and all of that is kind of wrapped up in, and the trachea, that's an important one too. All of that is kind of wrapped up in this very tight, stable, bony ring, and then covered with a fairly thick, not terribly distensible coating of fascia called Simpson's fascia. So even fascial restrictions in that area can create problems with movement of venous fluid, lymphatic fluid via the thoracic duct and right lymphatic duct, and etc. I like this view for two reasons. One, you're looking directly down into that thoracic inlet from a superior perspective, which you don't see very often. And again, you can see that it is a fairly narrow space, but it also illustrates the relationship of the scapula and the clavicle back to the axial skeleton, and therefore, the forces that come through the upper extremity, how they relate. And one of the things that we commonly think about in our minds when we're visualizing anatomy is we think that probably the scapula is in a somewhat coronal plane, and it actually is on much more of an angle. So try when you're trying to imagine it that it's not in a coronal plane flat up against the posterior aspect of the ribs. And the same goes for the clavicle. It's not in a coronal plane. The acromial end is much further posterior than the sternal end. So between the two of them, they sort of wrap around the lateral aspect of the rib cage to anchor the upper extremity to the axial skeleton. But I think it's just important to remember those relationships, because we have this tendency to think about them both being in a coronal plane, which is obviously going to be physically impossible for them to articulate and do that. The shoulder plays a big part in neck problems, thoracic outlet syndrome problems, and obviously upper extremity problems, and it's a very complicated mechanism. When we talk about the shoulder joint specifically, what we're really talking about is the glenohumeral joint or the scapulohumeral joint, where the head of the humerus sits in that glenoid fossa. But the rest of the shoulder girdle also involves all these other regions, and most particularly we have to think about the acromioclavicular joint, the sternoclavicular joint, and the scapulothoracic joint. Some authors certainly do also include costosternal and costovertebral, which makes a lot of sense to me, but other sources that you might read will only have the first 5. When we start layering muscles on top of that, some of the muscles that we need to be thinking about from a clinical perspective and looking at our patients are going to involve the ones that kind of integrate the cervical spine down into the thoracic spine and with those ribs. So the longus capitis and longus coli, and this is a nice view of the scalenes through here, but we will be looking at them in another one. This is a little cleaner picture of how the scalenes attach without all the viscera in the front of the thoracic cage is removed. And you can see the space between the anterior and middle scalene on this side over here, where that neurovascular bundle has to come through, is fairly small. And the anterior scalene is the one that is most useful in trying to bring exhaled first rib superiorly because of that anterior attachment. When you look at it again back with this view, you can see the artery coming back through between the anterior and middle scalene on this side, and then the posterior scalene is not shown on that side, shown much further back here. So that one is going to be not as useful for bringing up an exhaled rib that is got pump handle motion restriction, but occasionally even in these upper ribs you get bucket handle motion dysfunction, and because of its more lateral orientation you can sometimes use that to help you treat those kind of dysfunctions. This one is a better depiction of that neurovascular bundle and how it can sort of, the scalenes can have sort of a compressive or almost scissoring effect on that first rib and with the first rib on that neurovascular bundle. The scalenes usually attach from C4 through 6, sometimes further up than that. And it's important to look at the cervical vertebra if you're trying to treat rib dysfunctions and they're not resolving. Then you start to layer on more of the external muscles, the lateral group, and you've got the sternocleidomastoid and then the trapezius, both as the more superficial ones that play an important clinical role sometimes. And in the front, the hyoid muscles oftentimes can have they're one of those things we don't think to look at, but they can attach right down into the sternum and mediastinum and back to the scapula. And so when there is dysfunction in any of those structures from an articular perspective, and you're having, again, difficulties mobilizing them, it can sometimes be worth looking at the anterior part of the neck and some of those smaller muscles that may be maintaining dysfunctions. Levator scapulae, again, is another very important integrating type muscle because it's a connection directly from the upper extremity back to the cervical spine via its attachment at the scapula. And then the deep posterior muscles with the splenius and semispinalis and all of those that then further transmit down into the thoracic spine and again function to keep them working as a unit with the cervical spine and in an integrating fashion. And then those deeper, smaller little muscles that can maintain type 2 dysfunctions in the thoracic spine that can be very important in patients with the kind of presentations that we're going to be talking about. The more superficial musculature, I like these pictures because they really give you the big picture. The superficial trapezius is very clinically significant because it attaches to the cranium, cervical spine, upper extremity, thoracic spine, and down into the thoracolumbar fascia. So you've got a muscle that is, dysfunction can affect several anatomical structures. And the same goes for latissimus dorsi, from the sacrum up through the lumbar and thoracic spine and then all the way up into the upper extremity. This also shows the serratus posterior superior and inferior, which can be clinically significant, especially the superior one because it frequently develops myofascial trigger points that can give a radiating pain pattern. We'll look at that in a couple of minutes. And we just discussed latissimus dorsi, but again, one often doesn't think about how sacral dysfunction might affect a patient with upper extremity pain, but you have this direct anatomic connection that can very much influence and play a role in connecting those two regions. Intercostal muscles oftentimes are not something we pay a lot of attention to from a manipulative perspective, but there have been many instances where I've had a difficult time getting a rib to either move into inhalation or exhalation. And if I see two ribs that are approximated and not moving well, sometimes getting in and doing some myofascial release directly on the intercostal muscles between those two ribs can be extremely effective too. Serratus anterior is a big muscle that we don't necessarily think about a whole lot. It attaches to the anterior aspect of the medial border of the scapula, so all the way back on the underneath surface of the scapula, and then ribs 1 through 9. So you're directly attaching that scapula to the rib cage, again, thereby demonstrating how anatomic problems with the ribs can affect upper extremity pain. And when there is rib dysfunction, the scapula is sitting right on top of them. And I have never seen a person with shoulder problems that did not also have some ribs in the area that were restricted. They almost always seem to get involved. The pectoral muscles are very much a player in upper extremity pain because of their anatomical attachments. From the clavicle, again, that only bone that really articulates with the upper extremity back to the axial skeleton, and pec major is all along the clavicle and then down to the sternum in ribs 1 through 7 and then over to the bicipital groove. The minor, though, sometimes is actually more clinically important from the coracoid process down to ribs 3 through 5. And you can see in this picture how that neurovascular bundle sits directly underneath that. And you can imagine how if that muscle was hypertonic, it's going to compress that neurovascular bundle right up against the rib cage. And the pectorals are covered in a very thick fascia again, and it has that kind of radiated pattern that kind of converges back to the upper extremity. It's kind of fans out. So when you're trying to do any myofascial release or treatment in that area, you have to think about fibers going in a whole bunch of different directions. The lymphatics in the region are, as you well know, very thick, thickly concentrated in that area, and can be clinically significant in because you can see that there can be poor lymphatic drainage when there is thoracic inlet dysfunction, clavicle dysfunction, anything that's keeping fluid from above the inlet being able to drain back into central circulation. Because of the wealth of lymphatics in that area, when there's dysfunction, you can also see a lot of fluid collection of passive fluid collection of low pressure fluids. And again, another really thick fascia that infests around all the different muscles and all the way around the back. So fascial restrictions throughout the cervical spine can have a big significant impact on the upper extremity. From a neurologic perspective, it's important to remember when you are looking at the cervical spine that the anatomy is a little different there again. These cervical nerve roots emerge out from above the same numbered cervical vertebra. So you end up having actually 8 cervical nerve roots. And then once you get into the thoracic spine, then it switches over and they emerge out from below the same numbered vertebra. The brachial plexus is, again, a huge structure, crucial to upper extremity function, sitting right between those 2 scalene muscles, being formed out of those nerve roots coming out of the cervical spine and traveling through several structures that can put the neurologic function to the upper extremity at risk. We're going to go through that a little bit more specifically in just a minute. And that sympathetic chain can get significantly influenced by somatic dysfunction in that region, because what you can't see from this picture is that the sympathetic chain sitting right on the heads of those ribs as they attach back to the thoracic spine are covered in a very thick investing fascia that kind of keeps them applied up against that region anatomically. And again, when there is somatic dysfunction, putting abnormal tensions through that fascia runs the risk of affecting the function of that sympathetic chain. So when you are trying to diagnose a patient with upper extremity pain and neck pain, they very often will travel as a pair. You always, just like everything else in medicine, have to rule out the most serious things first. You know, you always want to. It doesn't do any good to have a patient with no somatic dysfunction if their heart's not working. So you always want to make sure that what you're treating actually is a mechanical musculoskeletal issue. If they do have radiating pain, you want to try to figure out the pattern in which it is radiating. Is it a dermatomal pattern? Is it in a pattern that's more consistent with some of the myofascial trigger points? Is it accompanied by any other neurologic symptoms like numbness, tingling, or weakness? Could it be one of the little cutaneous nerves or one of the peripheral nerves that is affected? So you want to try to pay specific attention to the areas that patients are having any of those neurologic symptoms. And if they are having both neck and upper extremity pain, you want to try to get a sense of if they are related to each other or is it something separate. More often when a person has neck and upper extremity pain, they seem to be more related, but there's many times where you can have upper extremity pain that is something local and mechanical within the extremity itself that's not so much related to the upper extremity pain. So you want to try to get a sense of if that patient sees them as connected, do they happen at the same time, or are they triggered by the same things, and so on. It's important to remember that the heart can produce an exact same pattern of pain as some of our other problems that we're talking about as we go through this that are more mechanical in nature. So just to rule out, you want to make sure that what else the patient's medical history might involve. Do they have diabetes? Do they have hyperlipidemia? So on and so forth. Remember that women have very atypical presentations as well. And so you want to make sure that they don't have any other symptoms like nausea, vomiting, diaphoresis, dyspnea, so that you can rule out that there is anything problematic that is not needing to be addressed by manipulation but needs more urgent care. Other red flags that you want to think about before you start instituting a treatment of um, a, a musculoskeletal treatment regimen is, are there any masses that might be causing symptoms and compressing on other structures? Is the patient having any swallowing problems? Are they having lymphadenopathy in the neck or edema in the upper extremity? Sometimes you can see that kind of a problem with a mass in the upper lung or in the neck. And so you want to be real clear on what it is that you're actually treating. Once you've got all the scary stuff taken care of, then you're going to go through the same history that you would any other time with all your PQRST. A lot of times with patients with upper extremity problems, occupational history is going to play a big role, either from an injury perspective or repetitive motion type problems, because given most people's fairly poor posture and not great workstations and not great habits, they can contribute a whole lot to patients with upper extremity pain. And sometimes that connection between the neck and the upper extremity is not just based on neurologic problems, i.e. something pushing on a nerve in the neck producing pain in the upper extremity. But if you have a shoulder problem that is presenting that is limiting range of motion in the shoulder, the patient is going to not be able to move the shoulder, but they still need to use their arm. So a lot of times they'll start to hike up the shoulder and the clavicle and scapula with their neck muscles to try to get their arm where they need it to go. So sometimes it's a shoulder problem that's creating the neck problems. So again, that can be a real challenge trying to differentiate between shoulder and neck. You know, use your neuro exam and physical exam to help you narrow that down. So you always want to do an overall physical inspection, make sure you palpate the cervical spine and the neck itself for other structures. Make sure you feel the thyroid and feel for lymphadenopathy. Look at your global range of motion and both for the region and also your segmental range of motion on a vertebral level. Your neurologic exam always has to include, for extremity complaints, always has to include these basic findings. Strength to test your motor function, sensation to test your sensory function, the reflexes to test that interneuron pool that creates the connection between the motor and sensory, and anything that might provoke or reproduce the patient's pain, so Sperling's or any other provoking maneuver. The Sperling's maneuver is usually the most effective for reproducing upper extremity pain that's related to cervical nerve root impingement, especially when it's related to arthritic changes and things that are creating lateral stenosis in the foramina. So you want to side bend and rotate the patient to the same side and extend, and then add some axial compression. If you just get local pain, it's going to be more indicative of facet irritation and much more indicative of nerve root problems or radiculopathy if you reproduce the patient's radiating pain. I would maintain as an osteopathic physician that you might want to use one of your hands instead of both on top of the head, that you might want to use one of your hands to help you localize your forces of side bending and so on and so forth to individual segments to help you narrow down which one is actually creating the problem. So you can do the exact same test, but do it at individual levels by using your other hand to help you localize that. And I think that that is a really much more specific way to get this information. The shoulder depression test can also be quite helpful, essentially testing for anything if there's traction on the nerve root, adhesions within the dura or scar tissue in the area or anything like that that may have created some inflammation in the dural sleeve and perineural tissues. So if you first stretch the head away and then put some compression down on the shoulder to put stretch within that region, as shown in figures A and B there. If that reproduces some of your pain, then you know that there is something constricting those nerve roots and not allowing them to slide freely in their pathways. The distraction test can be helpful. Instead of reproducing a pain, it's helpful if it actually resolves a patient's pain or improves it. So if they have something that is creating encroachment on that lateral foramen and is irritating the nerve root that way, if you apply a distracting force that actually creates more space in there, that can give you some better information. If you get a more local pain, right in the area of one of the facets, you may be putting some stretch into an inflamed capsule. So that might give you some information if it is painful. But most of the time, the distraction test is used to tell you if there's anything actually pushing on the nerve root. I'm not going to go through these in detail, but you definitely want to have this information burned into your brain. It's very useful for your neurologic exam for the upper extremity to help you narrow down what nerve root might be being affected. So whatever mnemonics you need to use for that one, you want to get that stuff in your head. Some things that can be helpful is that if you have a C7 radiculopathy, you're always going to have a middle finger and index finger involvement. And if you're going to have C8, if you have C8 radiculopathy, you're always going to have fourth and fifth finger, especially fifth finger involvement. You never have the thumb involved in a pure C7 radiculopathy. And you only will see triceps weakness in a pure C7 radiculopathy. The supraspinatus and infraspinatus weakness is only seen in a C5 radiculopathy, and the weakness in the hand, intrinsics and interossei, are only going to be seen in a C8 radiculopathy. So those kind of things can help you narrow down what areas you might be wanting to investigate. Don't forget the cutaneous nerves as well as the peripheral nerves that supply the skin, because sometimes just fascial restrictions where those nerves pierce through can create a very local cutaneous almost neuritis that can be very hard to explain any other way, but can be a very real discomfort for the patients. So with patients in these situations, I want to say again that you always want to look at the whole patient. I have absolutely seen problems in the sacrum and pelvis that have presented as upper extremity problems. My favorite example of that was a patient I had when I was an intern who came to see me for low back pain, but as part of her medical history said that she was having thoracic outlet syndrome and was planning on having surgery to have her first rib removed, which of course, you know, as an intern was very intimidating to me. But she had just started experiencing this low back and sacroiliac pain from doing step aerobics. Her history, when we teased it out, we found out that she had had a pubic symphysis diastasis 20-some years ago, right after childbirth, and her pelvis had healed in an extremely asymmetrical manner, which really flared everything up when she started doing these step aerobics. So I did osteopathic treatment for her, whatever she needed at that time, and not only did her low back pain get better, but it also resolved her thoracic outlet syndrome type symptoms, much to the surprise of some of her surgeons. And I always hesitate to tell stories like that because, again, I don't like to say them as if to say how great a job I did, but more in a way to illustrate that you cannot predict what dysfunctions are causing what symptoms, which is why it's really important to look at the entire patient. But when I've had patients with upper extremity pain, you almost always see dysfunctions in these regions, and so they always warrant being evaluated. but you're going to do that as part of a complete evaluation of your patient anyway. You very typically see cervical problems. Remember that in the lower cervical spine, your segments should side bend and rotate in the same direction, and typically side bend and rotate in opposite directions at the OA, AA region. Keep in mind that when a patient has undergone any kind of trauma to the cervical spine, that sometimes that pattern does not hold true. So trust your palpatory skills, not necessarily what you think you should be seeing. Look for type 1 dysfunctions in the thoracic spine, because they are often indicative of postural problems that you're going to need to address, and type 2 dysfunctions because of the impact that they can have on local nerves and ribs and so on and so forth. Look at all your rib motions, and keep in mind too that while we talk predominantly about ribs in respiratory mechanics, they can get dysfunctions in other movements as well. Ribs need to be able to move in other ways besides just what they do when we breathe. Otherwise, we wouldn't be able to turn our torsos because our ribs wouldn't be able to accommodate that kind of movement, but they can. So when you're evaluating ribs, if it doesn't, it may be very asymmetrical, but it may have good respiratory movement. So make sure you're looking at it from multiple perspectives. Other mechanical issues that can give you upper extremity pain are things like trigger points, counterstrain tender points, and postural issues, as we just alluded to. Some of the very common trigger points that we see that can give upper extremity pain patterns can be the scalenes. And if you saw a patient with that kind of chest wall pain, if it were on the left-hand side, and that kind of a radiating arm pain, you'd be concerned for cardiac origin, or at least you should. So if you do a workup on a patient you suspect to be cardiac and don't find anything, then start looking at some of these kinds of issues. Sternocleidomastoid can give both head pain and into the sternum pain in that kind of a region. The trapezius has up to actually 12 different trigger points in it, that a lot of times you can get pain in the neck that appears to radiate down towards the shoulder. That is just a myofascial trigger point, as opposed to, say, an upper cervical nerve root irritation problem. Levator scapulae can have a very similar kind of appearance. Serratus posterior superior, remember I mentioned that before. If you pull that scapula out of the way, i.e. have that person wrap their arm around themselves, it gets you to that rib angle, and you can find where that point is. Usually it's right around near the spine of the scapula. And again, you can get a very, what almost looks like a C8 radiculopathy from a structure far away from C8 down in the thorax and rib cage. The pectoralis major can give you arm pain and chest pain, and pectoralis minor again can give you these radiating pain patterns down the upper extremity. There are multiple places that the nerves themselves, not thinking about trigger points, but the nerves themselves can be irritated. And so I always try to get people to think about the pathways that these nerves have to travel, and how you can sort of evaluate each one of these areas to try to figure out what your upper extremity problem is. So I start with the cervical lateral foramina. So could they have nerve encroachment there from, say, DJD or a disc, then out through the scalenes, underneath the clavicle, between the clavicle and the first rib, then down underneath the pectoralis minor, and then you start to go, they start to divide up more into all of their distal branches and all of their tunnels, so you want to think about that as well. But those are all central areas where if a person's having upper extremity pain, somatic dysfunction can play a significant role. I mean, it can play a significant role in every single one of those things we just described. Thoracic outlet syndrome is a really interesting term, and I was doing some reading just to kind of brush up for this presentation, and I found 3 distinctly different classification systems that I found distinctly unhelpful, trying to really get a cohesive way of looking at it. But the biggest, most common things that you will see in all of the classification systems is that they will talk about neurogenic thoracic outlet syndrome, vascular, and then the non-specific ones. And the neurogenic, obviously, is going to be the syndromes that most affect the brachial plexus. And so oftentimes you will see the radiating pain, numbness, tingling, and sometimes atrophy, depending on how long it's been going on, of those muscles in the upper extremity, depending on what exactly is being affected. Vascular thoracic outlet syndrome is going to be more vascular in nature, so compression of that subclavian artery and or vein, and you can get swelling, you can get pallor if the arterial supply is diminished, and diminished pulses and a positive absence maneuver. But sometimes if it's just more vein and lymphatics, then you'll see the edema and the coolness, and patients will tell you that their arm feels cold and it feels heavy. Those are the most common things that I have heard patients talk to me about. And then the non-specific ones are what the majority of the medical world refers to. What I suspect is mostly somatic dysfunction related, and that non-specific diagnosis is the vast majority of thoracic outlet syndrome. It's only actually even being recognized by a lot of physicians as actually being a type of thoracic outlet syndrome. I've over the years have had many patients who have come after a big medical workup and told that they were probably imagining it because there was no neurogenic or vascular compromise that you could actually see. So therefore it must actually not exist. Where, again, I say this a lot of times, you know, a lot of physicians are very black and white. You either have some huge horrible thing or nothing at all. And I think that we as osteopathic physicians really kind of live in that gray area in the middle, which is great because that's where most of the patients are too. And in one of the classification systems, they actually even called that nonspecific, one of the classifications they used was disputed thoracic outlet syndrome. So you can tell that at some point in time when people were making that one up, that they didn't actually think that it actually represented thoracic outlet syndrome. But it really is the vast majority of the patients who present with this kind of a problem. And again, several of those areas that we just talked about where there can be neurovascular compromise are areas that they can all be diagnosed as thoracic outlet syndrome depending on what physician the person sees. So you can get that right out between that area between the scalenes, also called scalenus anticus syndrome. You can get it, the pectoralis minor syndrome or hyperabduction syndrome that can reproduce that person's pain if you put stretch on that. And then that area right between the first rib and clavicle, and they call that one costoclavicular syndrome. So all of those regions can really create quite a bit of compression in patients with thoracic outlet syndrome, and I can't urge you enough to evaluate every single one of those regions when you are talking about patients with these kind of conditions. The Adson's maneuver is used to see if you are getting vascular compromise in this particular position. Now, if you have the patient turn towards that same side, you're activating scalene a little bit, and they're presuming that the compression of the scalene muscle will be compressing on that artery, and so you have your fingers on that pulse as you bring that arm back into extension and abduction. If the pulse diminishes, then great, you have a positive test. If it doesn't mean that the patient doesn't have thoracic outlet syndrome. You might reproduce their neurogenic pain, and it might be that hyperabduction syndrome from the pectoralis minor. So again, you have to put all of the data together to try to come up with a cohesive idea of what is actually going on with this patient. You know, we talk about cervical ribs. It's not very common at all as a cause of thoracic outlet syndrome. If you really do suspect neurologic issues, you want to get an EMG and CT, because you know that compression on nerves for prolonged periods of time actually kills them off, so you want to make sure that's not an issue. Vascular imaging using MRI or Doppler can be useful. Another patient of mine who had a soft tissue illness, a connective tissue disease, and she was exceedingly hypermobile. Her bones just kind of moved all around. Actually gave herself thoracic outlet syndrome and an upper extremity DVT from that kind of the compression between the first rib and clavicle. And everything you do obviously is going to be dictated by how severe and what kind of symptoms the person has. So you wouldn't order every one of these tests for a patient you thought had thoracic outlet syndrome. Obviously, it's going to be based on what you actually see. One of the common treatments that they do is that first rib or clavicle resection, which, boy, that seems mighty drastic to me. Obviously important if you can't get the person well any other way, but that's forever. And you got to, as I said, you've got to evaluate every one of those sites where compression can take place for both articular somatic dysfunction and muscle problems, spasm or hypertrophy that may be compressing those somewhat vulnerable structures. One of the things that I've found is that if you can't fix a cervical spine dysfunction that you're having trouble with, something below one of its neighbors is causing a problem. So always look at the upper thorax and upper ribs. And then the same goes in the opposite direction. If you can't fix those things, look in the cervical spine. And if you're not getting those, either you're not doing the right techniques, which is not very likely actually, because usually just about everything will work, or you've got to look somewhere else. There's something else that's creating the problem and you just haven't found it yet. Posture is a huge, huge thing in this setting. The typical postures that we have create issues at almost every one of those anatomic sites that I just discussed as being potential problems, areas for compression. So most people sit with a very slumped forward posture, as that person on the left-hand side does, with their head very far forward, their shoulders rounded forward, and that can really create trouble. You know, when I instruct patients for good posture at a sitting environment, I talk about right angles. So an elbow, something to rest your elbows on if possible, so that you don't have to use your muscles to hold your arms up. Lumbar support forces you to sit in a more erect posture. 90-degree angles at the elbows, wrists, elbows, knees, and hips, and the wrists should be 180 degrees or out straight completely if possible. One of the common things in Yanda's muscle imbalance syndromes that we hear talked about an awful lot is the upper and lower cross syndromes. And the upper cross syndrome should sound fairly familiar just based on the things that we've talked about. In these syndromes, the theory is that you have muscles that are facilitated on one side and thereby inhibiting the appropriate use of their antagonist muscles. So in what we call the upper cross syndrome, the facilitated or hypertonic muscles are the sternocleidomastoid and pectoralis, pulling those shoulders forward and getting that head kind of pulled out into a forward position. And posteriorly, the upper trapezius and levator scapulae become the facilitated muscles. From their, the neurologic reflex to inhibit their antagonists, thereby makes the deep cervical flexors weak, so the person kind of juts their head out and exaggerates their lordosis. And the lower trapezius and serratus anterior become inhibited, so there's nothing keeping those scapulae anchored down to the thoracic spine from the lower end, so they're getting pulled up and forward by upper trapezius and serratus and the levator scapula. Again, typical posture in an upper crossed syndrome, just another example of that. And from a postural perspective, I like this picture quite a bit. It shows that essentially the relative weight of your head is relatively zero, which is obviously not really true. It's going to weigh something sitting on top of your cervical spine, but the more it's over your cervical spine, the less the muscles have to actually work to fight gravity. And the further out in front of you your head becomes, the more it actually weighs for your body to actually hold it up. So it actually increases by around 40 pounds by the time your head gets way out in front, like many of us actually sit. Sleeping positions can be very important too. If you look at the picture on the left-hand side, the person on the lower frame is they're sleeping on their side, which is good, but they're sort of crunched way forward, their shoulders rolling forward, and all of those muscles that we just talked about being tight, like the pectoralis, are going to be, in a shortened position. Whereas if you can get the person to kind of hug a pillow or prop their arm up on a pillow that kind of keeps them from rolling forward, it keeps their neck and thorax in a much more neutral position. Other diagnoses that play a role in this kind of a setting that you want to think about if you're not getting a clear picture are beyond the scope of this lecture: temporomandibular joint dysfunction, rotator cuff problems, adhesive capsulitis, carpal tunnel, ulnar neuritis, all can have these kind of symptoms that you want to be looking for. And post-mastectomy syndromes really function very much like a thoracic outlet syndrome, so you want to definitely look at all those same regions in a patient with post-mastectomy symptoms. I just threw in some of the codes that we should be using for other cervical spine problems. It's always better in your coding. I know it's easy and quick to just code for neck pain when you are treating patients, but if they have something that's more specific, make sure you document that. It increases the complexity of the case that you're working with. So you want to be as specific in your medical record as you possibly can. Some of the common techniques that we look at, it's kind of a silly thing to say, because really anything that we do would be effective depending on what you see with the particular patient that you have. So what I'll do is just kind of go through some of the typical diagnosis and then talk about just some of the key things about the techniques that you already know that may help you get a little bit better results out of them. But again, the key point is looking at the entire patient, seeing what kind of dysfunction that patient has that may be contributing to their problems. And that's the end of the lecture portion. So I wanted to go over a couple of physical exam techniques that I like to use that I find helpful in this setting. Obviously, you all know how to do a good neurologic exam, so I'm not going to go through any of that. You know how to do joint range of motion. One of the things that I do like to do is to do my Sperling maneuvers a little bit differently than I've ever seen it documented. So based on my history, let's say I felt my patient might have a C7 radiculopathy. So I would localize my hands down to C7 on one side, and then I would side bend my patient towards that side, rotate my patient towards that side, extend them so that I could tell all my movement was going right at that one spot, and then apply my axial compression with the hand on top. I find I can use a lot less compression because I'm being a lot more precise with my movement. So it's going to be more comfortable for the patient, and to me it gives me more information. When you're doing the Adson's maneuver, if you have the patient extend their arm out behind them like this, make sure you have a palpable radial pulse before you do that. make sure you've got the arm out like that. You're going to have the patient turn their head towards you this way, and then if you bring the arm back, the pulse should, if it is a positive test, that pulse will diminish. But I would also say that if you bring the arm back, not checking pulses now, and you start, if it reproduces their pain and you're pulling on all of these muscles, that's giving you a little bit of an idea of that hyperabduction or pec minor syndrome that we talked about before. As far as techniques go, as I said before, pretty much everything that you know how to do is going to be helpful in this setting. Obviously, you're going to choose the techniques based on your patient's clinical profiles. So if somebody is in horribly acute pain and the muscles are terribly spasmed, HVLA is probably not going to be your first choice. Or if you suspect a cervical radiculopathy, that's probably not going to be your first choice. It's probably safe anyway, but it's not going to get you as far, and your patients aren't going to like it as much. In a lot of patients, though, with the chronic problems that you suspect are not truly neurogenic or vascular in nature, it works beautifully and sometimes has been the thing that made a difference in getting my patients better. So it's all going to be based on your individual patients. I'll have you go ahead and lie on your back here for me. Of the things that I find particularly clinically useful, doing cervical soft tissue I find extremely useful because a lot of times it's a good place to start. The patients relax, and you can kind of get a good sense of the somatic dysfunction without poking real hard on them. So if you kind of rest your head on the patient's hand, or your hand on the patient's head, and you find the paraspinal musculature, and then you're going to just create a little bit of an alternating movement. I'm putting a little bit of counter force with this hand, but not a lot. I'm not rolling their head around and making them dizzy. I'm not dragging my fingers across the skin. I'm putting enough pressure to engage that muscle and stretch it out kind of laterally away from the spine. Okay? And most patients like that quite a bit. And you'll find as you're doing that and you're working your way up and down the cervical spine, whether you know it or not, you're actually motion testing as well. So you're actually giving yourself an idea of if those cervical vertebrae will rotate in the opposite direction or side bend if you ask them to. So if I'm applying a force kind of more towards the ceiling, I'm asking his cervical vertebra to rotate towards the left. If I'm applying a force more directly towards me, I'm asking them to side bend to the right. So I can get an idea of, is there more somatic dysfunction in that area that I need to investigate further? Pectoral traction is one of the most useful techniques in this setting, because even if they don't have the true hyperabduction syndromes or actual compression of the neurovascular bundle in that area, they almost always have kind of protective postures where they're rolling their shoulders in and kind of sitting like this. So getting the patient to be able to get their shoulders back will help quite a bit and kind of free up a lot of that whole area. So I'll ask the patient to lace his fingers together for me like that. Kind of hold your elbows up for me while I grab your pectoral muscles. Now you can just let your arms relax, but keep your hands crossed. Just let them fall to your sides there. Now I'm going to use my body weight, and I'm not digging in with my fingertips. I'm kind of keeping my hand somewhat flattened so it's less uncomfortable for the patient. And I'm leaning back with my body weight to put some stretch into the pec major at this point. I can have the patient take some nice big deep breaths in and out for me, and increase my stretch as he exhales. I can focus in particular areas. The more I sit here, the more the pec major relaxes, and I can actually then start to curl my fingertips up underneath that edge of the pec major to get towards the pec minor. So getting that stretched out as well. And that also can serve to kind of give you a little lift on some of those anterior ribs, anterior aspects of the ribs, and bring them up into a better inhalation by pulling those muscles up like that. One of the things, you can let your arms relax. One of the techniques that I really enjoy and patients really enjoy and I find is very useful in getting lymphatic drainage out of the upper extremity and stretching the fascias really all the way back into the thorax and rib cage, is to start down at this area. And I'm going to have my hands on the patient's wrist, fairly firm grip. I'm going to have them all the way internally rotated. And I'm going to apply enough traction where I can feel that pulling right back up into his shoulder. And I'm going to just very slowly hold that position. I'm going to start to slowly progress, and the pace that you do this is dictated by the release of the patient's fascias. I'm going to keep that traction, constantly taking up that slack and internal rotation. Make sure your patient does not have a rotator cuff problem if you're going to do this. Once I get up to around, and I'm constantly putting traction and taking up that slack, when I get up around here, I start to shift into external rotation, keeping that traction, and until I feel it stretching all the way down into their rib cage. And I've never had a patient who didn't think that that was extremely helpful. They said it made their arm feel all kind of light and gooey, and they always asked me to do the other side. So that is a really very useful thing. The other thing that I find extremely useful is teaching patients how to stretch some of these things on their own. If I could ask you to roll onto your side facing the camera for me. Once you have your patient comfortable in a side-lying position like this, you want to get their hips and knees bent up to a place that kind of puts their lower body in a fairly comfortable neutral position that keeps them relatively stable. All of the action of this stretch is going to be in the upper quarter. So you want the lower part of the body nice and stable. And I always tell the patient that this needs to stay perpendicular to the surface that they're lying on. So I'm going to ask my patient to start with their arm out in front of them and imagine that they're touching the floor here and reaching as far as they can, but if you were lying on a floor, your hand would be out like that, okay? So you would, if you were lying on the floor, you'd be reaching as far as you could and pulling forward all the way down to the area of the waist, just like that. You're going to ask them to very slowly sweep that arm up. When they get about here, they're going to have to kind of flip their hand over, just like I did before. Nope, this way. Yep. And bring your arm all the way around back. I'm going to keep you from falling off. Normally, I wouldn't be here. He'd bring his arm back this way, kind of all the way through that whole range of motion, and then do it again back the other direction. Those are called arm circles. You can just let your arm relax for me now. Those are called arm circles and or shoulder sweeps. And the key is getting the patient to understand that the movement has to happen not just at the shoulder, but all the way through the thorax. So they're reaching their whole body. If you could sit up for me again and face the camera. And then some of the stretches that I find very useful for the patient is to have them grab on the same things when I did my lecture, if you saw it on myofascial trigger points, the same stretches I teach those patients. Have them hold on to the side of the table, sit up nice and tall, lean their body away, and that sort of anchors the upper extremity. Now you can stretch all those muscles that attach to it. And you can get the lateral muscles just by going straight to the side. Bring them back to neutral, drop the head forward, and then go off to the side. That's going to get the posterior ones more. Come back to neutral and lean to the side, but kind of look up that way and get more of the scalenes and the more anterior musculature. And you want to have them take nice, slow, deep, easy breaths while they're stretching, good 20, 30 seconds for each position. You want to have them come always back to neutral before they change positions. The other stretch that's very useful is through that pectoral region for people. And so if we imagine that I had a wall here, I would ask my patient to come up against the wall, put his palm against the wall at about a 90-degree angle. The wall's in front of you, so you're kind of like kissing the wall there. Once you get up against that wall, then I would ask you to turn your body towards your left-hand side to start to put some stretch into these muscles. Okay? Same principles, take your time with the stretches. Okay, come on back. That gets all of these upper pectoralis fibers. But remember, pec minor is down angled this way. So if you bring the arm up about another 45 degrees and then do the same thing where you turn your body away and stretch these back, then you start to get very good stretch on that pectoralis minor. Okay, you can relax. As I mentioned before, all of the other techniques that you know, muscle energy, HVLA, balance ligamentous tension, functional, whatever you're good at and your patient's comfortable with and they will tolerate, that's what you use. It's more important that you understand that you want to look at the principles of the area, look at the principles of the techniques, match the technique to the patient that's in front of you. We are out of time, but think about counterstrain points in any of those muscles. And most of the time, I find that if I treat all the somatic dysfunctions first and the muscle issues, maybe, applying some myofascial, things like that, most of the time, counterstrain points, myofascial trigger points resolve on their own. Not always, and that's why we know to go and look for them. And that's all I'm going to have for you today. Thank you very much.